if there's any questions, and I want to thank everyone for your patience. Sometimes when I finish presentations, I feel like I've gone through like my personal therapy session. But it's very fun to talk about these things.
Wilson, I think there was a question specific to one of the projects or work you were doing on the ground in the chat, specifically to infant feeding from I'm sorry if I mispronounced her name, Olorunda Milola.
Okay, let me see. I can just read it myself. Let me see. Do such babies have to be hospitalized to be fed? How did that go? Also, if there's any situation where babies were sent. Okay. So what I'm referring to is like everyone looks at neonatal mortality. That's death in the first 30 days of 28 days of life. And it's a big deal, right? Like it's really dangerous to be 28 and less days old. That example, I was saying that the interventions that are pushed by the system are not as effective as they can be because the babies are starving during that process. So even though you can save a baby in the moment, which is great, I'm not against neonatal resuscitation, it's kind of fun, but once they are revived, they'll be kind of shocked and stunned, and they won't be fed by the system. Instead, they'll be like, oh, let's do kangaroo mother care and do breastfeeding. And for a significant number of those kids that represent neonatal mortality, they will be sick enough that they will have to be fed through a tube or with formula or both. And so that's what I was saying. But yeah, certainly most kids do not need formula or a tube. 100% breastfeeding friendly. I'm just saying when you're a sick baby, though, you often don't get food. Hopefully that made sense. All right, so let me see. Okay, here I have a question. What were the similarities in Rwanda, Indonesia, and Liberia? They're all the same. That's kind of the crazy thing. And by the way, I'll throw Harlem, where I live. It's kind of all the same. When I say it's all the same, it's like you're going there to be a contributing member of the community. You are joining the community. You're bringing unique skills, but also learning the process. And yeah, you need to have fun. It's all the same. It's all the same. In fact, I would say one of the most fulfilling things about being in global health is that I can land in Kigali, in Dakar, in Jakarta, Bangkok, Guate. I don't really care. I feel kind of at home. And it could be I have mental illness, but probably because it's kind of earned, right? You kind of like have spent enough time there, you're comfortable. And again, going back to, and if you're not immediately comfortable, I'm not saying don't do it. It takes time. It takes a little bit of time. But if you give yourself a little bit of grace and time, patience, and other people grace, time, patience, you'll find that it's all cool. Like we're all human. I know that sounds crazy. I don't want to say the word kumbaya, that drives me crazy, but I will say that it's all the same. To me. Okay. Let me see. I'm interested in developing. Okay. Let me see. I'm interested in developing global interventions, but I'm not sure I want to spend months in a year in a different country. Do you know? Oh, that's a good question. Like this person has the French fry thing I had, right? You're kind of like, you want to do it, but you don't really want to stay so long. And I would be candid and say, you gotta. You're not even gonna know what you're doing for 6 months, if not a year, right? And even if you were effective, let's say from New York, because in the Ebola response, right, I was mostly working out in New York, and then I'd come into Liberia, but people don't listen to you. They're like, screw you, you're sitting in and drinking like a cappuccino in your office in New York, and I'm in the field. I'm not going to listen to you. So at least initially, until you become like the director and people have to listen to you, I think you kind of have to do it, but it won't be a sacrifice. Like I lived in Liberia for 4 years. There are 4 restaurants in all of Liberia. I was happy as a little clam, right? It doesn't, all you need to be happy is community, feel like you're different, like in some way, and feel like you're making a difference. You'll be happy. So I would say, at least initially while you're young, unless the person, talked to me is 85, I would work in the field. You'll love it. You'll love it. What is one quality a public health provider should possess irrespective of their field? I mean, I think it's different for everyone, but I think in public health, you better like your constituency. I mean, you better like, whatever. You don't have to be a doctor. I hope you didn't think you had to be a doctor after this presentation. What I'm trying to say is that we are trained to look at very big picture fixes. But if the big picture fixes are not personalized by living in those places, being with those places, having friends of the people, quote, you're serving. Isn't it weird? Like, oh, I'm going to do all these interventions, but at 5 o'clock, I'm going to take my Jeep and driver and go to and have cocktails in the, in the hotel that no one can, afford except the foreigners. That becomes a problem. And there are iterations of that even here in the United States about a separation. So I would say maybe the one quality would be, joy in community and therefore working hard for community in the ways that need to be done. Okay. Should I answer one more or should we end it?
I think we have time for one more. If you
Okay.
want to take a stab, yeah.
Okay. Patricia, you want to pick one? I can't. I just got reading glasses, but I'm not comfortable enough with them.
Yeah. So we have one from Stacy. How do you feel like your perspectives on public health has changed as you worked around the world, and what advice do you give to an incoming student in the field?
My perspectives, and my wife gets mad at me for this, doesn't really change. I mean, I'm kind of the same person. However, I do think for challenge and for bad, the rules have changed a little bit. Like right now, it is kind of hard to do what I did. It's harder, like because of the awareness, the correct awareness of the colonial construct of aid, bilateral construct of aid. Organizations, including the IRC, they kind of don't like to send us Americans to the field. Now, I think that is kind of like throwing the baby out with the bathwater, because I think, I remember my first interview with Partners in Health medical director, Joya Mukherjee, and I said to her, I was very young and very ideal, and still ideal, just not young. I said to her, I know I'm going to Rwanda and I know I'm going to learn a lot. Like I know I, don't know traditional medical practices, and I'm totally open to it. And she said, "What are you talking about? You're going there to help create a hospital, right? They don't have cadavers for dissection. There are no x-rays. You need to deliver Western medicine at a system level skill with kindness, but you're still bringing it in." So I think what needs to happen is that we still bring in the skill, but I think of the greatest triumph for me in Liberia was not to create that poster, but was to elevate a nurse assistant to the level of clinical director. That person now runs the diabetes clinic that I started. That person continues to improve Liberia, whereas I haven't really said Liberia for a while because I'm not there. And so I think the challenge is to go abroad But there are ways for organizations to still do that without being so bilateral. So I was like, whenever I go to a place, I always train someone to take my place. Like it is true. Like the best leadership is you die and people are fine, right? I mean, sad, but you died, that's fine. So in terms of the intervention, hopefully people like shed it here. But yeah, so that was my approach to it. That thing has changed, but like I think the awareness, the awareness is better, but I think there has been a little bit of a, cutting of the whole arm off for the wart. But come here and I'll help you get out. I'll help you get to the field.
All right. Well, thank you so much, Dr. Wilson Wang. And thank you to everyone for joining us. This marks the end of our time here. I just wanted to quickly remind everyone that events are still going on this week. Tomorrow we have implementation science with Dr. Emmanuel Pepera, followed by urban health equity on Thursday, and we're wrapping up the week with an event on labs and lab opportunities here at GPH. I'd also like to tell everyone that we will be circulating the recording of all the events this week, sometime next week. So once we wrap up this week of events, we'll share that link with everyone. Wilson, if there's any other additional questions that students or prospective students may have, can they reach out to you directly, or
Yeah,
send us an
when they
email?
get the slides, my contact is there. And
Perfect.
that would be a pleasure to interact with younger, more vibrant, smarter people than
Awesome.
this generation.
Yeah, so we'll send over that information for you to submit any additional questions you may have. But in the meantime, please reach out to us if you have any questions, you want to know more about the program. You can talk to any one of us here on the call, or we can connect you with someone else from our team. We really just like to make ourselves available to you. So once again, thank you for joining us, and we look forward to hopefully continue seeing you this week. So thanks everyone. Thanks again.